We just finished our second podcast. I was talking with my friend and colleague, Scott Curtis, and we talked about the knee meniscus, and Dr. Curtis and I were talking about how someone with knee meniscus pain would present, how meniscus, person with meniscus pain gets worked up, what treatments are appropriate, both non-surgical, and we had a good discussion of surgical as well. The imaging findings that you expect with meniscus and the limitation of some of those imaging findings. And so anyway, bottom line is that if you have meniscus pain or are interested in meniscus pain or know someone who has it, then this is going to be a very interesting podcast to listen to or watch if you have the video. If you don't have meniscus pain and have no interest in meniscus pain, this would be a good one to skip. But if you do, then I hope you enjoy. Welcome to the second Princeton Spine and Joint Center podcast. As we said, we're going to be doing some deep dives and some conversations with other kinds of healthcare professionals and other people. Today, we are doing a deep dive on meniscus injuries and the meniscus in general, the knee meniscus. So if you're interested in knee meniscus, this is going to be the conversation you're going to want to listen into and be a part of. I'm joined today by Dr. Curtis. Scott joined us going on 2 years ago from his fellowship in Atlantic Health Center. I said that right? Working
Atlantic Sports Health.
Atlantic Sports Health. I'm sorry. Atlantic Sports Health, working among other teams with the Jets and a lot of sports and a lot of weekend warriors. And anyway, he's the director of our sports medicine division here. Mm-hmm. And so I thought it would be appropriate for us to have you come in and talk about do it this way.
Yeah.
I'm talking about knee meniscus.
I'm excited to be on the podcast.
This is it.
Yeah, this is awesome.
This is it. So today we're talking about knee meniscus.
Sure.
So why don't we start with just basics. What is the knee meniscus?
Yeah, so the meniscus, first off, you have two meniscus in each knee, a medial one and a lateral one. So basically the meniscus are the two pieces of cartilage that separates between the two long bones, the femur and the tibia. And basically the role of the meniscus are like the shock absorbers, right? So every time you walk, you run, you jump, the bones try to make contact with each other. And it's the meniscus that really take the brunt of the force between the two. And because of the nature of, everyday life, walking, exercise, our occupations, over time, the meniscus can be injured. So they're really subjected to a lot of force, a lot of injury, and we see this all the time in the sports medicine world. So I thought it was it's a great topic. When you came and asked me about what topics we should talk about, I thought that this was a great one to speak of. It's
one of the more common things that we see. As you
yeah.
said. So when someone comes in and they have knee pain, what are the kinds of things you'd want to think about when you're thinking, or be looking for if you're thinking meniscus?
Yeah, so just like anything in musculoskeletal, the cornerstone of getting, kind of the formulation of the differential diagnosis is getting a good history and a good physical exam. With meniscus injuries in general, people obviously complain of knee pain, but they also might complain of what are called mechanical symptoms, buckling, locking of the knee, feeling like their knee's going to give out. When I hear those words, a patient explaining that to me, I start thinking of the meniscus. And so that's one of the key points of the history. In terms of other things, I always try to separate, is this acute or is this chronic? Because the treatment and the diagnosis may be a little bit different. So if there's, let's say I see one of my athletes who are coming in here saying that they were running or they were playing basketball and they twisted the wrong way and now their knee got really swollen and they're having these mechanical symptoms, I'm thinking more of an acute injury. If it's more somebody who I know has osteoarthritis and they're not complaining of these mechanical symptoms, I'm thinking more of a chronic degenerative tear. And so those are kind of the things that I initially think of. When I start doing my examination, I'm doing a whole kind of approach to the entire musculoskeletal system, right? Because our bodies are not just the sum of parts, throughout our body. So I'm the first thing I'm doing is watching you walk. I'm looking at your foot without shoes and socks on, seeing, do you have flat feet, high arches, low arches, because that might put different pressure areas on different parts of the knee. And then when I start doing a more focused exam, I start doing some meniscus maneuvers, some of the compression testing, McMurray's testing.
Trying to recreate the...
Exactly. Which, when you look at some of the data in terms of sensitivity and specificity, they're not great, the meniscus maneuvers, but they can help to kind of rule things in and out, or at least formulate my thought process.
Something that a patient asked me last week was, what did I mean when I asked her if her knee was locking?
Yeah.
Can you describe locking?
Yeah, so locking is a sensation where, it seems like it's common sense, where your knee basically straightens out and it locks up on you, where you cannot move it, you cannot flex it. And that's a lot of times indicative of a meniscus injury, because the meniscus, if it tears and then flaps over itself, it can prevent you from flexing that knee. And so that's more of a serious meniscal injury, or especially if it locks up and you really can't unlock it.
Although I will say I've had that.
Have you?
I had a meniscus injury when I was a kid, and then again when I was I did the Broad Street one in Philly.
Wow.
And after that, but we didn't train for it. I was a kid, and I was in med school. And
so
afterwards,
you were really a kid. I mean,
depends on your perspective.
Okay, fair enough.
But it would lock. It would just completely, you couldn't move it. So we'll get into, I guess, how one treats that and all that in due course. But all right, so you've done your history, you've done your physical.
Yeah.
Maybe they have some locking or some other mechanical symptoms that makes you think of it.
Sure.
What kind of diagnostic workup would one do if they're suspecting a meniscus injury? Yeah,
so I mean, our first kind of imaging modality that we tend to go for is X-rays, and X-rays are really helpful to look at the bones and the joints, and maybe some calcifications within soft tissue that might indicate different types of injury patterns. But it's really hard to see the meniscus on X-rays. Short of it being completely calcified, you cannot see the meniscus. So the next step, or the best modality to look at the meniscus, is an MRI. They're very sensitive. The MRIs, they can pick up subtle meniscus injuries. Actually, a lot of studies are saying that MRIs are too sensitive, that they pick up a lot of false positives. So, the report would read that there's a meniscus injury, and, they'll go see an orthopedic surgeon. The surgeon looks with the scope and actually doesn't see a meniscus tear. And that's one of the drawbacks. So you and I, I'm sure, both have a lot of patients who say, Doc, I think I injured my meniscus, let's get an MRI. Well, I don't know if that's always the right answer.
And not just that, but even when you see a meniscus tear, even if it's really there,
right,
there's a large percentage of patients who have meniscus tears.
Yeah.
Forget not even patients. A large percentage of the population.
Sure.
With meniscus tears and no symptoms.
I read one study that 70% of people diagnosed with osteoarthritis of the knee will have some degree of meniscus tear.
Yeah.
So think of how many people that we see, and obviously we see a lot more than the general population, but think of how many people are out there with knee arthritis. 7 out of every 10 person who has ever been told that they have knee arthritis will have some degree of meniscus tear.
Yeah.
That doesn't necessarily mean that they all need surgery for a meniscus tear.
Yeah. And younger people too. I mean,
sure.
not with those numbers, but you're going to see younger people that have MRI. So that's one of the things. That's one of the conversations that we have with patients on a daily basis. Is yes, the MRI shows X. It doesn't necessarily mean
exactly. And I always tell patients, I treat people. I don't treat MRIs. So let's say an MRI does show a meniscus tear, but you have no pain, you have no mechanical symptoms. Why would I send you to get potentially an invasive surgery or talk about different, injections if you're not having any problems whatsoever?
Right.
That would be treating the MRI, and that's not the right thing to do.
A lot of times I'll have a patient who has a meniscus tear. We'll treat it conservatively. Yeah. It gets all better. And then but they're still, in their mind, it's still, but I have this meniscus. And they ask, is the tear still there? Yeah. And the answer is, the tear's still there. It's just asymptomatic. Right. And so, the question turns to, but I want to play soccer, I want to do this, I want to do that, do I need surgery? Right. And, and to me it's like, well, by the same logic, if we get an MRI of your other knee, which has never had an issue, and there happens to be a tear there, Are we doing surgery on that?
Exactly.
How about the rotator cuff? How about the hip?
Yeah.
And it would never end, right?
Of course.
That's the point.
It's unfortunately in our age of technology, there's a large burden of knowledge. Yes, we know it's there, and now it's in the back of my mind,
Right.
and now I can't get rid of it. So I think a lot of it is patient education, patient counseling, and hopefully they understand that, yes, there's a tear there, but it may not cause any problems, and do everything you want to do.
Can you talk a little bit about the difference between acute versus chronic? You mentioned it before, but how do we conceive of those differently, and what kind of implications, I guess, do those?
Sure. So usually an acute, and this is similar to any kind of musculoskeletal injury. It's all about kind of the mechanism or onset of pain. So when I think of more acutely, I'm thinking of more of a higher level activity. There's some inciting incident that the patient remembers. I did something to my knee. And that could be, playing pickup basketball or twisting the wrong way, picking up a child and turning. Usually an acute meniscus injury involves some sort of flexion and rotation pattern, because that kind of puts a lot of stress on the meniscus, just the anatomy part of it. A lot of times I'll have a meniscus injury acute suspicion when I'm thinking of other ligament problems, because meniscus injuries acutely can occur with an ACL tear, for example, or a lateral collateral or medial collateral ligament injury. So I had one patient who was a skier who had a really bad accident, had an ACL tear, but I also suspected a meniscus injury too. Those types of injuries, when I'm thinking of more acutely, I'm more quick to get more quick to do an MRI, because something happened that we need to figure out exactly what's going on, because there might be concomitant injuries that need to be addressed too.
Right.
Now, in terms of more chronic, on the other hand, that's usually more of an insidious onset of pain. It kind of gets intermittent. They typically will have a history of osteoarthritis, pain with flexion, with walking, going up and down stairs, and it just seems to be getting worse. And then when I do their examination, I'm really trying to provoke those meniscus symptoms.
Is the way you approach them, assuming the meniscus injury is isolated and there's not a concomitant ligament tear, is the way you approach an acute versus a chronic tear going to be different?
Well, honestly,
from a treatment perspective.
From a treatment perspective, a lot of it will actually depend on the level of activity of the individual. So if this is a high-level athlete, and we know that there's going to be potential for maybe not a whole lot of time for rehab, or of getting an X-ray first and then rehabbing it and then getting an MRI, I might be a little bit quicker to get an MRI, find out exactly what's going on, and then approaching the treatment based on their expected activity level. That would probably change. I'd be a little bit more aggressive in terms of treating that. But other than that, a lot of it might depend on the type of tear. So there's multiple types of tears of meniscus injuries, some of which can cause different symptoms, some of which may occur over more of a chronic period. There's some literature to suggest that certain types of tears should be treated differently. So for example, one of the tears is called a bucket handle tear, where the piece of meniscus that's torn will then flip over and cause more mechanical symptoms and large irritation within the joint. And there's some literature that suggests that should be treated with surgery, as opposed to the more conservative approach with physical therapy and, let's say, injections or anti-inflammatories. And if it's in a higher level athlete, I'm a little bit more quicker to refer to an orthopedic surgeon for an evaluation with that. So sometimes it matters, and sometimes it doesn't.
Yeah. It's a good segue into treatment. So I guess, say you have someone who, let's just say we have the MRI, and let's say all the suspicions are that you have a meniscus tear.
Yeah.
And you have an MRI that confirms there is a meniscus tear. Mm-hmm. I guess we should probably take two generically different types of patients, right? The 30-year-old or the 20-year-old who was playing soccer on the weekend and had an acute injury and tore their meniscus, and maybe the 78-year-old who stepped off the curb and had acute pain on their inside of their knee, or maybe a slower progression towards that. How do you go about with thinking about how you want to handle those?
So to me, actually, there's three categories.
There were three.
Yeah, there's three. But this is why we have this dialogue, and this is why we educate people. So everybody thinks of it in terms of age, which is kind of right. I actually think of it in terms of more of osteoarthritis and how much arthritis is present.
Right.
Because we have seen young people, like 40-year-olds, who have really bad arthritis at an earlier age. We've also seen 80-year-olds who have very minimal arthritis. And I'm not going to necessarily treat the 40-year-old different than the 80-year-old. I'm going to treat the knee with advanced arthritis differently than the knee with minimal arthritis. Yeah. But generally, age and arthritis correlate, and that's why everybody kind of assumes it's all based on age. So I separated into three groups. The first two groups that you talked about, so the young individuals who probably don't have much arthritis at all. The older individual population who has probably moderate to severe arthritis. And then the group in the middle, maybe the 50-year-old, 60-year-old who has, let's say, mild to moderate arthritis. In terms of the first group, the younger individual who has minimal arthritis, if they're coming in, it's for a meniscus injury that I'm suspecting that, chances are it's more of an acute meniscus injury. And they have probably a higher level of expected activity. Maybe they have a higher demanding job that they need to do. I'm a little bit quicker to get further imaging, such as an MRI, because I want to know exactly what's going on. And if there's a tear, I present all the options, but I'm not totally against referring them to an orthopedic surgeon for a surgical consultation. The issue with surgery in the meniscus in general, and we'll touch about this, is the surgery itself is difficult to treat the meniscus. So in other words, when they do a surgery, it's very difficult if there's a tear to sew the two pieces back together. The reason why is the blood supply is great on the outside of the meniscus, but as you go deeper into the joint, it's very poor blood supply. And without blood supply, if you sew it back together, it's not going to heal well. So what they do actually is they take, in most cases, they do what's called a meniscectomy, where they take the piece that's torn and they just shave it off or take it out. And so when you have a piece of meniscus that's torn out and you have the two bones, and the meniscus is the only thing that's separating the two bones, and I take it out, the bones are going to get closer and closer together. So we know from way back in the late 40s that if you were to take the meniscus out, it accelerates the arthritis process. So going back to the younger individual who has very minimal arthritis and has an acute meniscus injury, I'm okay with sending them to an orthopedic surgeon to do a meniscectomy or a meniscus repair if it's on the periphery, because it's not going to accelerate the arthritis process. They don't really have much arthritis process. Maybe they might develop it later on in life, but maybe they would have developed it later on in life anyway, whether they had the meniscus surgery or not. Which is why, on the flip side, if I have an older individual who has advanced arthritis and I send them to an orthopedic surgeon to do a meniscectomy to treat the meniscus tear, well, they're going to be asking for probably a knee replacement in the next couple of months after that, because we know that it's going to accelerate the arthritic process. It's better to, if you're going to do any kind of surgery, actually do the total joint replacement and treat both the advanced arthritis and the meniscus.
Yeah. I had a patient who was, she was in her 80s, and she had gone before she saw me to get a meniscus because she had knee pain.
Sure.
And she went to an orthopod somewhere not around here, and she had a meniscus surgery.
Yeah.
And she said it was. I said, "How did you feel afterwards?"
Yeah.
She said, "Oh, it was great."
Mm-hmm.
And but like a couple of days later, it was hurting again. It's
of course.
Like, yes. She has severe arthritis.
Yes.
She had severe arthritis in addition. Yeah. If I can just, I wanted to. The issue about a 20-year-old having meniscus surgery or not, or the idea of what happens when you do an arthroscopic surgery for somebody with a meniscus tear. I've read and had discussions with orthopods on both sides of that. Mm-hmm. So I had a patient who was a young guy. I don't remember how old, but he was a young guy. He had a meniscus tear.
Okay.
And he had gone to an orthopod who said, the guy basically had very little symptoms anymore. And I wasn't even treating him really for his knee, but we were just discussing his knee. And he had gone to his orthopod, to an orthopod who wanted to do surgery on the knee, because he said that if he didn't do the surgery, that leaving the tear like that is going to lead to an accelerated arthritic process. To which I said, to me, it's the opposite. It's
Right.
more the way that you were just talking.
Sure.
Which is that once you go in and you start scraping around,
Yeah.
it's probably a very minimal problem. But on the margins, you're likely more accelerating a potential arthritic
Sure.
cascade, although not a very large element of the conversation at that age, depending on how bad the symptoms are. So I called the orthopod. He was someone I knew. And we went back and forth about it, and he said, "Yeah, no, I'm not really sure," And I had to say, like, I went into the literature at that point, and I looked, and I was like, yeah, there's not really much
not a
there.
whole
It's a, but it just, I guess, and I think it's a little bit of our upbringing, you and I
Right.
being, in the non-surgical.
Yeah, and I always tell
And-
patients that, look, I'm biased. I am not a surgeon. I try to do things conservatively sometimes,
Yeah.
but. I think your point is very well taken because
Yeah, it's not even my point. It's just that just recognizing that there is this other side of that coin.
the
which,
point that I was going to say
Yeah.
that is well taken is how symptomatic is this person?
Right,
So if they were
right.
coming in here
That's clutch. Yeah.
for really, let's say, back pain or shoulder pain, and you happen to start talking about the knee and it shows a meniscus tear, but it wasn't really that big of a problem, I probably wouldn't send them
Right.
to a surgeon, even though it's a younger individual with no arthritis. The question that I would expect to get from the patient is, if I don't do surgery, will the tear get bigger, or what will happen
Yeah.
to the tear? And it's a valid question, and there's always the possibility if you don't fix it, of course, depending on a certain activity or certain level of, whatever your overall health is, that
Right.
it can get bigger
Right.
and it can get re-aggravated.
And I would think, sorry to cut you off, but I would think like when you were with the Jets, for example,
Sure.
or with a big, especially with a professional athletic team, but I suppose you could have the same conversation about collegiate and and younger. If you have a big tear, right, but you have minimal symptoms, but you're in off season. How do you? That's a controversial. That's got to be
with
tough.
sports medicine, the question is always about yes, symptoms, the health and safety of the athlete, but there's a lot of logistics and timing, as you're saying, with the off season.
Right.
So I remember there was a high level athlete who did have a meniscus tear, very minimal symptoms, but demanded a lot from his knees. And the approach was, we're going to finish the season. Maybe there were like 4 or 5 weeks left in the football season. We're going to finish the season, and then we're going to fix it afterwards.
Yeah.
And worked out well. But there's always the possibility that you're playing on, asking a lot from a knee that has a torn meniscus.
See, I think that gets even more interesting if, let's say, that you play it out and the guy gets better.
Yeah.
Then he doesn't hurt by the end of the year. Now you're sitting there with this guy who feels great, has this big tear, is going to go next season and demand a lot of his knees or her knees.
Yeah, of course.
How would you?
I think that the general consensus.
That's a hard one, right?
Yeah, I think the general consensus is that you still fix it.
Yeah.
I mean, this guy still was playing with pain, and that's, I would think, especially in the context of football, you're going to be playing with pain, and there's always the potential for it getting worse when you play.
Right.
And I think and when I was with the Jets, Elliot Hirschman, who is like the guru of knees, he's over up in Lenox Hill. He taught us a lot about knees, and he always says it's a conversation first. To talk and counsel the patient about really, what are the pros and cons of doing surgery versus no surgery.
Yeah. I'm sorry. I veered us off topic.
So we were talking about, I think, treatment approach.
Yeah.
I guess.
Let's go back to treatment approach. Yeah, because I think we didn't. Maybe you were talking about the 3 different types.
Yes. So we talked about the younger individual, the older individual, that we try to do the conservative treatment first.
Yeah.
Meaning physical therapy, medications to control pain. And really a lot of them will get better if you treat the underlying osteoarthritis appropriately. What do you do with the middle group? And this is where the gray area is. And so the middle group classically is a 50-year-old who has some arthritis, but not bone-on-bone arthritis, maybe mild to moderate, who just doesn't feel right, felt like they did something and they have a meniscus tear. What do you do? The studies are all indicating that, again, if you do surgery right away, you could actually accelerate the arthritis process. So it might be better to avoid surgery first. So the studies are now indicating that let's try the conservative treatment first, because a lot of people will do well with it. Yes, you still have a tear, But typically at that age, you may not have the same kind of physical demands as, let's say the 20-year-old athlete, the 30-year-old athlete, but you still want to work out and be active and, do all the things you want to do. Conservative treatment with the mainstay of it being physical therapy to strengthen the quadriceps, the butt muscles, the glute muscles, most people will do well. However, there were studies that show people who try the conservative approach first, 30% of them will still complain of pain, mechanical symptoms, and have crossed over into the meniscectomy group. So I think to me, the most important part is counseling the patient and talking with them and saying, let's try this approach first. It's, non-invasive, relatively speaking. We'll try to control your pain. We'll try to strengthen your body. And overall, the majority of people do well. However, there is a minority of people who will still wind up with surgery anyway, based on the studies. Yeah. Where you'll fall in, I can't really say. But I think it's appropriate to do the conservative treatment.
And you get a sense of them, how bad the tear is, what their symptoms are, what their general physique is, and all that.
Yeah.
All right. So speaking of non-surgical care, what is someone comes in? Let's take the 40-year-old.
Yeah.
40-year-old guy. We keep doing guys. 40-year-old woman.
Sure.
Has a meniscus tear, knee pain. It's moderately bad.
Yeah.
Doesn't want to even talk about surgery or does.
Yeah.
Where do you go with that?
Yeah, so to me, the way I look at being a physician is it's my job to hopefully make an accurate diagnosis and present all treatment options for you and answer your questions and counsel you based on, evidence-based medicine and my experience. And where we go is it's a shared decision. The patient, at the end of the day, it's their body, right? You have the right to make the decisions. My job is to counsel you, and hopefully we come to an agreement on that. And so when I see the 40-year-old with a meniscus tear, I try to at least present the conservative treatment. And so I say, okay, first off, well, how's your pain right now? And what are your limitations due to the pain? And, if the pain, and I hate this pain scale of 0 to 10, it's unfortunately the only objective way, so to speak, that we can put towards a subjective feeling of pain.
Yeah.
But, if their pain is, let's say, 8, 9, 10 out of 10, they're having a lot of inflammation, it's severe, well, then I'm a little bit more aggressive in terms of pain control. So we'll talk about doing a corticosteroid injection to decrease the pain, a lot of, maybe a nerve block to help reset some of the pain fibers. We'll talk about different medications such as anti-inflammatories, topical medications, natural medications, all of which might be helpful to control their pain. Yeah. And then once their pain's under better control, that's what we're talking about. Can I break in for 1 second?
Yep. Corticosteroid injections. This is a pet peeve of mine.
Sure.
When doing a corticosteroid injection, I'm not sure how to ask this because you know what I think about it.
Sure.
But, what's the importance of using image guidance in terms of injecting anything into a knee?
Yeah, so you and I are on the same page here because we both read the same studies, and we've talked about this before. It is extremely important to do any kind of injection with image guidance, and all of our injections here at the office are done with ultrasound guidance, at least in terms of the knees, because when you look at the actual literature, when you're doing an injection blind, meaning the old school palpation way, you feel the spot and then you stick the needle in, studies show that it's only getting into the place that you want it to get into 70% of the time. When you do it with an ultrasound, it's about 90 to 95% of the time. And I think with fluoroscopy, you do fluoro, it's closer to like 98% of the time. So it's super, super important.
It's a pet peeve because there's basically, really, I think at this point it's fair to say there's no excuse for not using some kind of image guidance. Probably ultrasound, although maybe in some particular cases you might want to use fluoro, but for the most part it's ultrasound is widely the most, the best way, I would say. That the literature would say, to access the joint. And even the most experienced people, you and I, well, I'm older, so I'll just talk about myself. I've done lots of knee injections, and my friends have, without using any kind of image guidance, because it was before it became standard of care. And you would never convince any of us that we ever missed a knee injection. Ever, impossible, it didn't happen.
But the studies would show that.
But the studies are 100% sure that yes, over and over they're very consistent, not just in the knee, but in other other joints as well.
Right.
But here we're talking about the knee, that 30% of the time we missed.
And if you
Which
think
is
about
crazy.
the amount of people that we see and injections over our career,
Right.
it's a lot.
It's a
and
lot.
if you're missing 30%, that's a lot of patients.
That's a lot of people that you're
And
not,
then
yeah.
people will go to a more aggressive treatment plan because
Right.
they said, well, I've had an injection
Right.
done and it didn't work.
Yes.
Well, did it really work
Right.
or
Was it-
not work, or did they just miss?
And you and I have both had, but we'll talk about viscosupplementation later, but you and I both have had patients who had viscosupplementation, which is the lubricant that you
Sure.
put into the joint, at other places and other times that were not image guided,
Right.
they didn't work. And they come and it's like, well, did it not work, or did
Yeah.
it just was it not always in the joint? Was it not always
Right.
optimally placed? And then sometimes when we do it again under image guidance,
It
lo and
seems to
behold,
work.
oh, they're
Yeah.
better.
Oh.
And you have to, I think it's pretty clear that at least some of the time
Sure.
before it was being missed. So anyway, that's just
Yeah.
it amazes me. It amazes me that today, we still have to say those things because it seems like there shouldn't be anyone out there doing it non-image guided.
No,
So it's a pet peeve. And anyway, I just wanted to.
Yeah, absolutely.
I wanted to bring it up, even though.
And just to touch one last point on the ultrasound is, even though I'm using it for therapeutic purposes, I'm using it to guide my needle and make sure I'm in the right place.
Right.
I'm not a radiologist who's using it for diagnostic purposes. I still know the basics of the diagnostics that I
Yeah.
could tell you broadly. Yes, there's a lot of inflammation. There's fluid in there. I could see the meniscus. I could see the ligaments. So I think that just adds an extra bonus.
Yeah.
Because I could take a look at the structures when if I'm just doing it blindly, I'm just feeling around.
Yeah, it's an added bonus. But
Right.
again, you can't know you're in the joint unless you know you're in the joint. And you
Absolutely.
can't know unless you can see it. So
Couldn't agree
anyway,
more.
yeah. So sorry.
So let's say we get their pain under better control with a corticosteroid
Right.
injection. To me, when we do an injection like that, it's really designed to get your pain under better control so that you can tolerate a strengthening program through physical therapy.
Yeah.
To me, that's the mainstay. And so if you have, let's say, tolerable pain, then we don't have to do a corticosteroid injection. Let's just get right into therapy. Now, if your pain starts increasing because you're overusing it, or then that's something we could address. But to me, the cornerstone of treating the meniscus tear conservatively, meaning without surgery, is physical therapy.
Yeah.
And there's a lot of great therapists in this area and who have really worked hard with some of my patients and have gotten to a place where they don't even remember that they had a tear. I
Yeah.
saw them, a year later for something else, and I said, "Oh, how's your meniscus? How's your knee?" And they're like, "Oh yeah, I have a tear. I forgot about that. I did
Yeah.
physical therapy."
Yeah, yeah.
So I think.
Although
that's
ideally they're still doing their exercises.
well,
but-
of course they're still doing the exercises. It's a pet peeve of mine.
Right.
Patients will come back, and not
Yeah.
do their exercises.
Yeah, I think, as a general rule, we tend to look at the injections or medicines as more of a window of opportunity or a gateway to allow the exercises.
Yeah.
Because I guess I'll ask as a question, how do the exercises, why, the question that I think we get a lot, or at least I get a lot, is how is therapy going to help? Like why, I'm still going to have the tear, right?
Yeah. No, it's a great question. And I always have to tell them that the therapy is not going to fix the tear. Whether that's a rotator cuff or meniscus, or it's not going to fix your herniated disc. What it's going to do is it's going to strengthen the muscles that surround the area that's injured and offload that joint. And so if these muscles are nice and strong, then they can support the area and put less pressure on the meniscus that's torn. When these muscles are weak and atrophied, every time you walk, there's no muscle to really help support that area. So you're going to put more and more impact on the area that's injured or torn. And so what people get into trouble with when they transition from a physical therapy program to home exercises, they, kind of life gets in the way. And, they get a little bit lazy or they forget to do it. And then pretty soon, those muscles that they've built up and are nice and strong and feel great, they start to atrophy, and they basically have now lost everything that they've gained in therapy. So now we have to go back to square one.
I think too, though, a big, well, another pet peeve, I suppose, or I think a common mistake that people make when they are done with physical therapy and they're feeling good and they go home and they're all jazzed because they had this terrible knee pain and now they don't have knee pain and they've been doing therapy and they see that it works, is they take an hour of exercises and they say, this is what I'm going to do.
Right.
And no one's going to keep doing an hour of
course.
exercises, 5, 6, 9 months after they can't remember, what it was like to have any pain. So ideally, to me, I always tell them, look, when you leave therapy, make sure you leave for like 10 minutes.
Yeah.
You know, maybe for a knee, even more like 6 minutes.
Yeah, it doesn't take that much.
It doesn't take that much. To maintain it. To get there, you need to do more.
Yeah, of course.
But once you're there.
Yeah, and then, you know, I just say make it part of your routine. If you want to put like a little note like knee exercises next to your toothbrush to remind you to do this on a regular basis, you don't have to do it every day. But, you know, the majority of days out of the week, every other day, I think is really, really helpful and makes the difference between somebody who is continues to be out of pain compared to somebody who comes back to see me later on because their pain is now worsened.
Right. And I think, you know, a big hallmark there too, I feel like is, or a big way for people to wrap their minds around is just to remember, you know, that a lot of people, what did you say, 70% of people with a certain amount of arthritis, I think it was like 60% or thereabouts over 60, a lot of people have meniscus tears and don't have any symptoms.
Exactly.
So we don't need to change the picture. We need to change you to someone that has that picture and doesn't have any symptoms.
Yeah, absolutely.
You know, and that I think, you know, helps sometimes to understand why it's okay that the tear is still going to be there when you get an MRI later.
Yeah.
I always want to my knowledge, I don't think there are any studies, but maybe you know better. Has anyone ever looked a couple of years later after someone doesn't have any symptoms, just scanned a bunch of knees? I don't think they've ever done that. It'd be
in
interesting
terms of an MRI?
Like just to get another MRI.
I know that they've done...
like someone that went through therapy, they're all better, maybe they got some shots, and now, you know,
so
2 years
I know
later,
that they do
no
that
symptoms.
with, they've done those studies with PRP injections, like regenerative medicine, where, which we'll talk about, where they basically do a pre-intervention MRI, shows the meniscus tear, do the intervention, and then check another MRI to see is there anything that's changed structurally. And I'm sure they've done that in the surgical literature too. Therapy, I'm not sure.
I don't think so. I don't think so, but it would be cool. if anyone wants to give a grant to fund some MRIs, that would be...
That's exactly what it would be.
That's the problem. No drug company is going to be interested in...
Probably not. Maybe a physical therapy group.
Maybe physical. So I'm sorry, I digressed. So that's the therapy, right? It's offloading the joint to you're basically allowing the joint to rest, so stop seeing that force. I always tell people, look, gravity doesn't care. There's going to be force going through your leg. The muscles can either engage or not engage. If they don't engage, the knee can't get out of the way.
Exactly.
If they engage, they'll take the pressure off.
Yeah, and a lot of therapy, I'll focus on the generalized strengthening program, but as a sports doctor, I also like progression to sport-specific activity. So I see, especially in this time of year as the weather's getting nicer, a lot of tennis players and a lot of golfers. That puts a tremendous amount of stress when you do a golf swing. So much force goes onto the knee, especially as you're following through, that it puts a lot of pressure on the meniscus. So I will often in my physical therapy prescription say, okay, you'll work on pain modification, then the range of motion and strengthening, and then towards the end, you're going to actually get them into golf swinging mechanics. You're going to teach them how to swing the appropriate way. There's therapists in this area who are certified by Titleist and the World Tennis Association, and who are very good at sport-specific physical therapy. And so that's something that I really consider when I write a PT script. And
as part of that, and we've talked about this before, especially if the injury occurred during the sport, is to go back and look at the form to see if that might be contributing.
Mechanics can play a big role in it.
So
that's something to definitely correct.
Yeah.
It's really important. But once they're better, hopefully, then they continue and maintain it with the home exercises, and then we're basically done. At follow-up, if they're still having pain despite all of that, and they're still having mechanical symptoms, that's when we say, okay, we've given the conservative treatment approach the appropriate amount of time, you've done all the things the right way. You might just be in that 30% of individuals in this kind of group of the 50-year-old with moderate arthritis or mild arthritis who will now cross over into the meniscus surgery category.
Let me bring you back, because I think you... Because we're going back and forth in different things. So you have the person who didn't do, let's say they went through therapy, right? And they're still having pain. But there's steps before surgery right? Like, for example, you talked about the steroid injection. So something that I'll just say my perspective on it. Sometimes two different kinds of people. People that come in and they have a lot of pain and they're not going to be able to fully participate in therapy. Steroid injection under ultrasound guidance. Very important. But anyway, sometimes that can really be used to help take away the inflammation, allow them to participate in the exercises. The other group, though, the pain is either mild or just moderate, but they they feel like they can participate and they want to take a more conservative approach. So they go through, let's say, 6 weeks of therapy, and let's just say that unfortunately the symptoms are still the same. My personal take on that is that, look, therapy a lot of times is great about making the pain go away completely. Sometimes it's not, but that doesn't mean therapy won't work for you. Maybe we're just asking the wrong question.
Right.
And that's when I'll say, look, that's when it might be appropriate to think about using some of the injections we're about to talk about to set the clock back down to 0, and then go back into the therapy to use some of those exercises to make sure that the inflammation doesn't come back.
Absolutely. And a lot of times I'll say therapy may be appropriate, but it's not just the therapy. It's all about the timing of therapy. And so I think what you're getting at is if they're still having pain despite the physical therapy and the pain modification, is it that it's still the meniscus that's causing the issue, or is it the underlying arthritis that we might have to treat appropriately before?
Not necessarily. I'm actually saying that the meniscus itself, if that's still painful, right?
Okay.
Let's say, take someone younger. Take a 25-year-old, right? They have a pretty clear. It's just meniscus, right? There's no. It looks like a person that pretty clearly has an isolated meniscus tear. They go through therapy. They're still having a moderate amount of pain. It needs to get fixed, right? They want to go back to everything, but it's not killing them, and let's not put them into the pro sport category. So to me, at that point, it's like, well, we still have a lot of good options, right? We can, first of all, we could just try putting some steroid around it just to kind of reset it, take away the inflammation, and then use exercises. And then what we really need to get into, right, is the viscosupplementation, which is essentially a hyaluronic acid. It's the lubricant, or not. You're
Yeah. So I tend to think of the lubricant as when there's more arthritis, because that's what the studies are really based off of.
Yeah.
Now, have you and I both seen patients who, exactly like you're describing, who have no arthritis who benefit from it? Absolutely.
Yeah.
And so it is something I do consider. We talk about it, but I tend to think of it when, even with mild arthritis, I'll definitely go with viscosupplementation. If there is no arthritis,
fair enough. That would be sort of
that would be helpful.
Yeah, there was the fellowship I did. With our sports medicine component of it, we used to sometimes describe it as sort of, if you think of a meniscus tear as like a pothole in the road. Yeah. Right. And then there's the lubricant to the extent that it's going to work in folks with straight up meniscus tears, sort of paves over that pothole. Although to your point, the studies are very clearly geared not towards that population.
No, but what you're describing is actually how it works, right? But it's more, at least when they looked at it from an arthritis perspective, not paving over the potholes in the meniscus, more over the cartilage within the bone itself. But in theory, it could absolutely work for the meniscus too, which is why you and
that conversation. And it's also that conversation you have with the patient. Look, we have this option, right? And just to kind of back it up just a half a step, the viscosupplementation is...
So it's basically a synthetic form of what your joint naturally makes, something called hyaluronic acid. The way I kind of describe it is it's like putting WD-40 in a creaky doorway. Helps, especially with arthritis, kind of allow the joint to slide back and forth. It fills in those pothole deformities. It could help sometimes with the acute pain, especially if you're using other interventions like the steroid injections or anti-inflammatory medications or PT. But I like it more for the chronic, kind of maintenance. And so I like the car analogy. It's like getting an oil change on your car. You want to do the oil change before the car breaks down, not when the car is broken down and you're having a ton of inflammation. Because a lot of patients will come in when they have 8, 9, 10 out of 10 pain and say, okay, it's time for the gel injection. The gel injections were probably best to, a month ago before you had all this.
Right.
But that's generally more for arthritis. For the meniscus, it's kind of hard to predict when it's going to really flare up on you.
Right. And also fair enough that when you have that person with a meniscus tear on top of the mild to moderate arthritis, that's really...
Yeah, that's when
I think a sweet spot.
Absolutely. I think that's the value in, okay, so we just treated it in terms of the meniscus. Maybe you're still having pain. You still have the arthritis. Let's treat that using the viscosupplementation injections. And if that helps with your pain, then we reintroduce some of the therapy and home exercises. And we know that we've hit both components of your knee issues.
When the viscosupplementation, this is a little bit of a setup, but when the viscosupplementation is effective and you feel, and the person with mild to moderate arthritis or mild arthritis and a meniscus tear is feeling good, now you send them back to therapy.
Yep.
And then do they need it again? Do they need this lubricant again, or are they good to go?
Yeah. So again, it's that the old car analogy. I think it's helpful. So for the studies will show that the hyaluronic acid injections on average will help for about 6 months. And again, that's more for the arthritic component, but it's kind of general for most people. I've seen plenty of people who get great relief for beyond 6 months. I've seen people who are 6 months on the dot, they start getting return of pain. I've seen some people who unfortunately don't respond at all. Yeah. It's important to remember that peak effects of the hyaluronic acid are actually about 4 weeks or a month after the last injection. So there's a lot of different types of injections. The efficacy is about the same for all of them. We tend to use the 3-shot injection series, and I say, look, a lot of patients will come in and say, between the first and the second, and say, look, this isn't working. Should we even pursue it? I said, it's not really supposed to work right away. For some people it does, right. But we have to complete all 3 of them, right. And then we have to wait a little bit of time to really say, did it work or did it not work? In people who it works, I will tend to kind of wait and see to what extent do you get relief from it. Hopefully, we don't need to see them again or see them for other issues besides the knee. But I don't think it's a conversation to have. Again, informed, shared decision making. For some people, they want to come in every 6 months and maintain it because they don't want to have that pain again. And that's not necessarily the wrong thing, because I think it's helpful to continue to do routine maintenance. For other people, they say, well, let's see how long this lasts. And that's okay too.
There's a conversation that sometimes I struggle with, or I think it becomes sort of a 6 on one side, 6 on
exactly,
half a dozen on the other, where I'll have a younger patient, anywhere from teens even, but I can't really think of a teenager this has happened, but maybe late teens, early 20s into 40s, 50s, whatever, where they either had just a meniscus tear or they had that patient with mild to moderate with a meniscus tear on top. We do the visco. They're great for 6 months.
Yep.
And just as a segue, as a sidebar, I always tell people, look, the more you can continue with your exercises, the less likely we're going to see each other about this in the future. But for some of those folks, who just, like you said, like clockwork, 6 months later it comes back. And I've had more than a few times where the conversation becomes, wow, we've done this like 3 or 4 times now. The person is great. They have no symptoms in between, but it seems like every 6 months we really have to be back and doing this. Would they be better off just getting a scope, right? And because I say, look, I don't know. It depends on how big a deal. So I usually say, why don't you go talk to the surgeon?
Yeah, I don't think
go have a conversation.
Exactly.
And you don't have to have it, but at least you'll realize what we're trying to avoid, because it's not that big of a deal to do it. On the flip side, what we're doing is certainly less invasive. So it becomes that conversation you're talking about.
And that's and some of the things that I will say in that situation is, look, I agree with you. Let's have a conversation. Just because you're meeting with an orthopedic surgeon doesn't mean you're committing to a surgery. You're just hearing their perspective on things from a different viewpoint, from a different background and training than what I do. And there's nothing wrong with that. You should get as many opinions as you want in order to feel comfortable. The second thing I always say is any intervention that we do medically, whether that's a pill, physical therapy, surgery, injection, you always have to weigh the risks versus the benefits. Nothing is completely benign and nothing is 100% foolproof. So, we always just have to talk about what are the risks and benefits of continuing these injections versus the risks and benefits of doing surgery versus the risks and benefits of doing nothing. Yeah. And it's a conversation.
Yep. Yeah, agreed. All right. So, in between, say you take the mild to moderate, where we can, there's a pretty clear evidence-based path. So they've done therapy, they had a steroid injection, let's say. Let's say they did some viscosupplementation, and they still have this pain. And let's give it a moderate score of some sort. And they want to avoid surgery. Right. They just say, look, for me, I don't want to do it. What fills that gap?
Yeah, so this is where the new field of regenerative medicine really comes in. And it's an exciting field. I'm very optimistic about it, but the studies are mixed on it. And so when we talk about regenerative medicine, we're mainly talking about like PRP injection, platelet-rich plasma injections. The thought process is, well, there's an area of injury. What if we can take our own natural cells that will help heal an area of injury within our body, concentrate it down to what are called platelet-rich plasma, and inject it into the area of injury. And it's really helpful at least in my opinion. However, the studies on it are so broad and a mixed bag. And there's a couple of reasons why the studies, I think, are mixed. I do think it's helpful. I think that in theory it could be really helpful. And in practice, I've seen it be very helpful. It doesn't necessarily work for everybody, but I think it's a great alternative if you really want to avoid surgery. The problem is that because the studies are mixed and it's not approved by insurance, so it is all out of pocket. If it was approved by insurance, I'd probably be using it first line for everybody because there's really no major side effects like when you introduce a corticosteroid or a medication by mouth. It's your own natural body's products. All we're doing is basically putting it into a centrifuge, spinning it down, and then reintroducing it into you. The reason why I tend not to go for it as the first line is purely monetarily because it's not covered by insurance.
Right. And how does it compare with viscosupplementation of those in the studies that have been done?
So the reason why I think the insurance companies are reluctant to pay for it because they say, well, the studies are mixed on it. There's not a whole lot of standardization right now in terms of what it's being used for. So with PRP, everybody's kind of blanketing that term. And I talked with Zach Perlman and Jason Kirkbride about this extensively, about when do we use PRP for meniscus injury versus when do we use it purely for arthritis versus a rotator cuff tear versus tennis elbow or Achilles. There's so many different kind of studies out there specifically for one thing. And then the question is well, how much PRP, how often? There's so much variability. That's why the studies are mixed, so to speak. There's no standardization. But when you look at some of the literature for specifically the meniscus injuries, again, there's variability because is this a chronic degenerative tear or is this for acute tears? Is this for people who have no arthritis? Is it for advanced arthritis or mild arthritis? Again, the studies are mixed. And
this probably almost, I think to get into the weeds of it, probably deserves its own own podcast, video space, so that we can really explore, and also with Jason and Zach and everything. All right, so back onto this person. So they've gone through these things, I guess, and then the next thing would be to talk about. Well, that's what I wanted to ask you. I knew I was stalling for something. A question that I get asked all the time. So I imagine you get asked it too. Is what, if any, is the role of nutrition, supplements? How do you feel about that? How do you talk to patients about that?
So I'm actually a big natural medication fan. I think it's one, I think it helps people under the right circumstances. Two, there's some good literature to support various supplements. And where I trained, there was a nutritionist there who provided us with a lot of information about supplementation, mainly as an anti-inflammatory. So I actually am a big fan of it. A lot of it is over the counter.
Are there any supplements in particular that you like?
Yeah, so glucosamine and chondroitin has been around for a while. Basically, when you take it, it's kind of like the building blocks of what the underlying cartilage is made up of. To my knowledge, there's really no studies that show that it's significantly harmful. Biggest side effect in terms of that are a little bit of GI symptoms. The studies will say, well, does it really help? Maybe for some people, for others, not so much. When I say, you might want to try it, you could try it. If it doesn't help you, then you wasted a couple of bucks at the local CVS or whatever it is, and it's not hurting your body. If it's helping you, great. Then continue taking it. Other natural medications, I'm a big fan of arnica, arnica cream, which is a topical cream. It's from the plant arnica. It really helps with pain. It's not a great anti-inflammatory, but it does help modify pain, so I'm a big fan of that. Turmeric and curcumin, which is from the spice. Really, studies show that it helps a lot with various inflammatory issues. So I'm a fan of that. Not personally, I just don't like the taste of turmeric. So I don't like that.
My father-in-law eats it.
Does he really?
Yeah, he does.
I don't like it. But I know it's from a medical perspective, it can be helpful for you. And there's the one I really like is actually fish oil, omega-3 fish oil in high doses. And the studies behind that is actually more for rheumatoid arthritis and some inflammatory MSK issues, autoimmune musculoskeletal issues. But I've, in practice, have applied it to more osteoarthritis and the wear and tear, and patients seem to get better.
Yeah.
More at higher doses, like 3 to 4 grams per day of omega-3 fatty acids, I think would be beneficial. Anything above that, you don't get great musculoskeletal benefits, and you actually increase the risk of, things like bleeding. But at a dose of about 3 to 4 grams, it's in a safer range, and I think it could be really helpful for you. In addition to other studies that suggest it could be helpful for blood vessels and cardiovascular health.
That's the thing I say about a lot of these is like, look, to the extent that like turmeric or curcumin, and I would add to that bromelain, which is a pineapple extract, that's like a COX-1, COX-2 inhibitor, and maybe tart cherries. These things, I'm not really convinced that they're necessarily going to help your knee, but they're probably generally healthy things to do.
Sure.
Like I think if you're a 20-year-old with an acute meniscus tear, good luck with curcumin on that.
Sure.
If it's not going to hurt you, and if it makes you feel better,
why not?
Why not?
Yeah.
There's a quote that I like from Voltaire. He said, "The art of medicine is entertaining patients while nature takes its course."
Okay.
I think if you're a 25-year-old who has an acute meniscus tear and you load up on curcumin and tart cherries, and you give it a couple of months, and then you're better. I think time just helped you a lot.
I think it was a couple of months.
But the other stuff didn't hurt you, and if it made you feel better, then more power to you. Maybe it's a good thing. There's a bunch of studies about all of those things. Maybe less so with the bromelain, but all of them generally, have some benefits. And they all have anti-inflammatory properties. So.
Sure.
To your point.
And of course, the best natural anti-inflammatory, I always tell patients who have acute swelling and pain, is ice. Ice is, I think, a very underrated utilization, especially when there's acute swelling. But to your point, I think that time is the great healer of a lot of things. And, a lot of what we do just kind of delays it.
Speaking of that, I realized I mentioned that I had a meniscus tear back on the Broad Street when I was in med school. I knew it would lock, so I knew it was meniscus, even in med school, and I just didn't do anything. And for a couple of weeks, it would lock on me, and then it would unlock, and it would be really awful when that happened. And then it stopped doing that, and then it was pretty much gone. And then a few years later, it kind of was a little sore. And but I do, I work out.
Did you maintain your exercises?
I do maintain my exercises.
That's important to do.
And but I have, to be fair, during fellowship and end of residency, thanks fellowship, I wasn't able to maintain the exercises, and my knee was fine. So I think there's an element of sometimes you need to get past the acute phase, whether that's with therapy, injections, time, rest, and sometimes maybe I'm sure there was a bit of luck in that too.
Oh yeah.
And maybe I just jinxed myself and.
Probably.
In the next podcast, I'm like, God damn.
Meniscus again. Well, come back and see me and I'll treat you.
We'll be talking. Anyway, so all right. Anything else we want to get to?
No, just one last point. We've been talking a lot about statistics and studies. At the end of the day, statistics are population-based. They're not fit for every single person. So I always tell patients, look, I could throw all the studies at you, but let's look at you as the person first and foremost. And that's, I think, the cornerstone, whether, we're talking about the meniscus or back issues or, hand and wrist issues, it's all about the patient. And I'm happy to have a conversation with them, explaining everything that I can, but at the end of the day, it's your body. So that's, I think it's super important, right? You could use that if you want.
That's it. Yeah, I'm gonna have to, well, I'll play this back and try and memorize. That was good. You absolutely, but 100%, right? At the same time, because people also have different goals. And there, not to segue too much, but just one, I remember there was an older lady I was taking care of, and she was saying that I said, how are you doing? I think we had done visco, if I remember right. And she was doing great, sort of. She was really good. She was very happy. And I said, well, is there anything you can't do? She said, well, I can't walk in the museums with my kids. And I said, oh, okay, well, then we should address that. Do you want to be walking in the museum? No, I hate going to the museums. And I said, well, then maybe if you're feeling good in the life that you want to be living, maybe we don't need to, and it was just a funny sort of...
What kind of museums is she going to?
I don't know, but it's just, to remember, obviously, what you just said, to address, how you go about things, according to the patients,
It's the most important thing.
Most important thing. Yeah. Perfect way to end this.
Good.
Thank you very much.
No problem.
Thank you for listening and maybe watching if you were watching. And until next time.
All right, sounds good.
All right.